And good morning, Nigeria. Today we shall examine new strategies in malaria control.
Nigeria, with the highest malaria burden globally, accounting for 27% of cases and 31% of deaths, is now taking bold, innovative steps to turn the tide against this scourge.
Absolutely, Victor. For years, malaria has been a heavy burden, costing the country between 32 billion naira and 132 billion naira annually. But with these new strategies, Nigeria is edging closer to what once seemed impossible, eliminating malaria.
Now, some of the key measures include local production of malaria commodities, public-private partnerships, state-level tailored approaches, and the rollout of the R21 vaccine beginning in Bayelsa and Kebbi states to protect our children.
And yet, funding remains a big challenge. There's still a $350 million gap in the 2025 plan. But, Victor, this gap also signals
investment opportunities in commodity, in production, diagnostics, and treatment, with huge potential for job creation and economic growth.
Exactly, and that's why today on Good Morning Nigeria, we're focusing on the country's renewed strategy to defeat malaria once and for all. It's a national health priority, and with Nigeria accounting for a quarter of global cases, the stakes could not be higher.
Well, we'll be exploring the new initiatives from innovative vector control and stronger funding mechanisms to community engagement and the malaria elimination program. The big question becomes, will this be the game changer?
So join us as we put these issues in focus, the challenges, the solutions, and the hope for a future free of malaria. I'm Henry John. It's a pleasure to welcome you to today's edition of the program, Good Morning Nigeria.
And I am Victor, as we are live on the network service of the NTA. Many thanks, Ibrahim Hamidu, for that background report. And to begin this conversation, which is on new strategies in malaria control, let me begin introducing our guests, and I'll start with Dr. Michael Adekunle Charles, who is here with us. A pleasure to welcome you to Good Morning Nigeria.
Thank you and good morning.
All right, let me also welcome Kalui Kago, who is an actor. And no, he doesn't have malaria. We welcome you to Good Morning Nigeria.
Thank you very much. Happy to be here. That's the thing you talked about, so I'll talk more about it. So let's go on anyway.
All right. We have other guests joining us for the conversation also. Right here in the studio is Dr. Kolawole Maxwell, the chair, Malaria Technical Working Group. Many thanks for joining us, sir.
Good morning.
All right. Also here is Ayo Ikpemoye, a civil society lead. He's also joining us for the conversation. Many thanks for joining us.
Thank you very much. Thanks for having us.
All right, let's begin. Let me begin with Dr. Charles. Now, Nigeria still bears the world's highest malaria burden. And so, what's different with this strategy that we haven't tried before?
Thank you very much. And, you know, malaria, as you said, Nigeria bears the biggest burden. But if I go more globally, we still lose over 600,000 children every year. You know, if you break it down, that's 1,600 children every day, which is the equivalent of about 5 plane crashes on a daily basis. 95% of those are on the African continent, and 30% of those are Nigerian children. So you can see that, you know, the scourge that malaria is causing is really, really bad on the economy, on our population. Now, the strategy we've adopted over the past decade is, you know, looking at malaria elimination just from a health perspective. Yeah. What we're saying now is that we need new strategies, we need new ways. It cannot just be the health ministry that is fighting malaria. We know the causes of malaria, we know the stagnant water, we know the potholes, the drainages, and all that. So we're now saying that the fight against malaria has to be a whole of society approach. We need education, we need infrastructure, we need agriculture, we need everybody, and that's why we've also engaged our colleagues from Nollywood to say, join us in the fight, And that's the only way we can beat this deadly disease.
All right. Many thanks for your response, Doctor. But like you said, we've been dealing with malaria for a long time. It's not like a movie, right? This is real. It's affecting every one of us. These strategies that you're currently, trying to bring on board to deal with this, what makes you and your team think that it will work, or it will change the narrative?
Part of the strategy is about leadership. And we feel and we know that we have the right leadership in place through the Minister of Health, Professor Pate. We've seen places in this country, in Nigeria, where we've made significant progress. Yesterday in Lagos, they were actually launching the pre-elimination stage, meaning that there is really a lot of progress that has been made in the state of Lagos. And if Lagos can do it, we believe other states can do it as well. So these strategies are working if we have leadership in place, if we have financing in place, if we have the right people to do the work in place, and if we have a whole of society approach.
What
which is
exactly
everybody.
is Lagos doing that is making it win the fight?
Lagos is treating, they're testing first and foremost, they're treating and they're ensuring that the commodities to fight malaria, to prevent malaria, are there. Bed nets are being distributed, insecticide resistance spraying of houses are being done, surveillance is being done, data is being gathered. So we know where the hotspots are. And that's what Lagos is doing, and that's what we're urging others to come on board as well and do.
All right, thank you very much. It just occurred to me that I didn't indicate that you lead the Rollback Malaria Program. Thank you very much for your initial remarks. Let me get to Dr. Kolawole Maxwell, who chairs the Malaria Technical Working Group. Now, technically speaking, what change is this likely to bring about by the time we start this whole new strategy? What change are we likely to see with it?
Yeah, thank you very much. Our expectation is that with this new big push, it's going to assist us not only to move faster, but to move in the direction of eliminating malaria in Nigeria. And as Dr. Charles mentioned, we've had, experiences of states that are progressing in Nigeria. Some of them might not have reached pre-elimination phase like Lagos, but we have a lot of states, Kwara State, Anambra State, that are making progress. And we are congratulating and wishing all our colleagues that are making efforts to make this possible. He mentioned that we will be looking at every aspect to make sure that this change is permanent and sustainable. And one of the things that we are emphasizing in the Malaria Technical Working Group is the issue of not forgetting the science behind the disease. What I mean by science is to remind ourselves that there's a parasite, which is Malaria falciparum, that is causing this, Plasmodium falciparum, that is causing this. And there's a vector, which is mosquito, that is causing this. And these two organisms, they do innovate themselves. They change the way they behave. They change the drugs and insecticide that they are resistant to. But we know that the basic public health science behind it is that if you can separate these two, if you can separate a mosquito from an infected person, and you do not allow the mosquito to transmit, and you treat the infected person, then mosquitoes will be in Nigeria, but they will not find malaria parasite to transmit. And so the elimination will be achieved.
I didn't quite get, how do you want to eliminate the parasite? How is that possible?
You treat the patient.
You treat the patient. Now, in treating the patient, you need drugs, right?
Yes.
At the moment, there's a growing concern about fake and substandard drugs, or if you like, drugs that are not effective in treating malaria.
Yeah.
What's the solution, in that regard? Because, there are so many reasons why that is happening. Importation, we depend on importation mostly for these drugs. We're not producing locally. All kinds of medical facilities, or if you like, pharmacies exist where quacks and all of that operate. How do you intend to deal with that chain such that the medicines that are available are medicines that are actually, good enough or
Yeah.
quality?
Thank you. I mean, you've raised very important issues that we need to tackle. A number of these issues are not malaria only related issues. That's one of the reasons why this big push is not only about people in malaria sector. It's about everybody. It's about the entire health sector. So the issue of the quality of drugs is not only quality of malaria drugs that is important. And before I even get to the issue of drugs, let me start from proper diagnosis. There are a number of people that have symptoms, that have fever, that have symptoms that look like malaria, but they are no longer malaria. And one of the things Lagos is doing is to make sure that for every case of fever, they are tested and it's established whether that fever is actually due to malaria or not. Let's imagine we've established it's due to malaria. That is when we get to the issue of then what type of malaria medication should you apply? And there are, I mean, it's combination therapy, but there are a number of them. And what NAFDAC is really doing, and NAFDAC has substantial processes in place to ensure that not only commodities, but even foods that Nigerians consume is of good quality. So we rely a lot on NAFDAC to ensure that all the drugs that are coming in are of good quality. But there's another stage. The drugs might be good, but is it prescribed as expected in terms of our health workers at all levels, hospitals, community-based, to make sure that those drugs are prescribed? If you have to use them day 1, day 2, day 3, you use them, I mean, it's prescribed accordingly. And then you get to the next phase, which is our caregivers, our mothers. Are they actually giving these drugs as prescribed? So you see a number of steps that we are actually mobilizing everyone to make sure that we actually eliminate this disease. And to let you know, one thing about Nigeria is that because of our enormity of our population and our diversity, we are noticing that some people are believing that can malaria be eliminated in Nigeria? The answer is yes. If it can be eliminated in China, if it can be drawn down so low in India, it's possible in Nigeria. And one of the things the big push is doing is to mobilize everyone. Let us have this consensus. Let us believe in this cause that it is possible, and we will surely achieve it.
All right, thank you very much. Let me get to Carlo now. Celebrities like you have influence. So how do you see your role in being able to, bring about malaria prevention in Nigeria?
Thank you for that question. I mean, going back to how you introduced me earlier, that I have no connection with malaria. Incidentally, I had malaria just about a few weeks ago.
Oh.
For the first time in so many years.
That makes the two of us.
Exactly. And it cost me my job, because you have to be very healthy to be able to be on set.
Were you tested, or you just assumed you had malaria? Because a lot of Nigerians assume
Yes, I was tested.
Okay.
Yes, to my shock. I had to find that out, amongst other things that happened. So my job was affected by it and everything. And when Dr. Charles called on me, I just jumped on it. Now, yeah, being a face or being a celebrity, as I might call it, certainly has an influence in motivating people. But on a larger scale, this is where Nollywood comes in, because we are the best medium to sensitize people through our movies and through our stories on how best to go about how these things that Dr. Kolawole talked about, the stages of prescription, adhering to what is prescribed by the doctor, specificity as to what drugs to make sure to follow the drugs that are being prescribed for the particular strains of malaria or whatever the case may be. Our medium is the best, through our stories, because we tell stories about ourselves, for ourselves, that relates to the everyday person. And what better medium is that to do? We can also work with telecoms companies to, inform the public or, help with financing and stuff like that. And also with mosquito nets and the use of mosquito nets, because it's kind of alien to some people having to go under the nets and stuff like that. So that's how powerful Nollywood, not just for myself, but for the industry as well, to collaborate with RBM to, have a cohesive inclusion with everyone to fight this malaria.
All right. Many thanks, Kalu. Mosquitoes are no respecter of persons, including Nollywood stars. And so, anyways, let's get to Aya now. Listening to all of this initiative and all, sounds very good. But I'm thinking how you think we can actually eliminate malaria in Nigeria, considering the fact that most Nigerians pay for, or rather take care of their health from out-of-pocket spending. And that's like a major challenge, right? They tell you that qualitative malaria drugs goes for about 4,000 plus these days. And you ask yourself how many Nigerians can afford that. Now, if we do not have, a health scheme that, caters for a lot of Nigerians such that they do not have to pay out of pocket, do you think this fight can be won?
Okay, thank you very much. The big push now seeks to mobilize everybody, recognizing that everyone has a role to play. The healthcare giver, the health insurance provider, the pharmaceuticals, the community leaders. We all come together. But it must start from a premise that we all accept the reality that malaria can be defeated. You see, we are in a place now that people have given up. People are just not comfortable, but just think that we're already beaten by malaria. So just do your best, you will get it, treat it anyhow you are. If you cannot afford high quality ACT, go and drink agbo. And and some of the side effects that come with that. So when you talk to the people at the community level, mothers, you find out that there is a lot of despondency. But the big push tells us that we can beat this situation. We don't have to accept it as our destiny. We are not destined to live and die with malaria. But if we are not going to do that, if we are not going to submit to that fatalism, then we all have to be up and doing. But somebody has to give us that push, put some impetus behind us. And that's what Big Push is about. Now to your question, Nigerians are poor. Not Nigerians are poor. A lot of community members are poor. And it's been established that malaria is both a cause of poverty and a consequence of poverty. Professor Jeff Sachs, a development expert globally, did a study of the poorest countries of the world. He did a chart. Then he did another chart of the countries that had the most endemic malaria in the world, that have the largest incidences of malaria. And he laid one chart on top of the other. They were exactly the same. So the poorest countries of the world are the countries that also have the most malaria. Now the question is, do they have malaria because they are poor? Or they are poor because they have malaria? It's both. Just like you said, imagine a family that lives on the minimum wage now have to treat 4 or 5 children every other month with 4,000 naira. For 2 kids, that's 8,000. Out of how much are they earning? And then when it's not just the cost of the drugs, when the child is sick, that means the mother cannot go to market to sell her products. That means maybe the father cannot drive the car that he drives. So see the loss of income, and yet they have to look for money to treat the child. And then the periodicity of the malaria infections drive down the ability of the family to make money, to earn income, and also takes what they have. So that's why we're saying now at this point that let's do something new. Let all of us come together and everybody understand and play their roles. As we go later, we'll see what roles the communities play.
Thank you. But from the citizens' angle, since you are from the CSO, yes, what do you think the people really want to see with this new strategy?
Yes. Number one, people want to see leadership by government. There has to be a galvanizing force. And that's why we're happy that our current Minister for Health, one of the first things he did was to call all of us together and say, let us rethink malaria. Evidently, what we have been doing in the past have worked to some extent, but we cannot continue to go that way. There has to be political leadership.
All right.
And then there also has to be an infusion of resources, money into the healthcare system. Then there has to be maybe now a reactivation of the health insurance system so that the community members can be able to pay for insurance, and that helps to drive down the
And government wants to make that mandatory now.
Yes. So if it is, and if it goes down to the level that people can afford, since insurance is a crowdsourcing pooling source of funding, then nobody bears that too heavy a brunt of caring for malaria.
All right, many thanks. Dr. Adekunle, I'll get to you, but just I'd like our viewers to know that they can contribute, they can send their questions, comments, suggestions, whatever it is concerning the topic we're discussing. The number is on the screen. So we look forward to seeing your messages. You can send either SMS or a WhatsApp message. So Dr. Adekunle, I'd like to get back to you now. You know, dealing with malaria, very important because, I mean, the country is losing so much as a result of it, and lives are being lost, which of course is a critical part of all of this. But it's not just about the cure, right? Treating, getting medications right. It's about the causes. Sanitation, poor sanitation is, I mean, one of the factors. I mean, this is the rainy season. We know a lot of communities are being flooded. That's also another issue, which of course would, you know, breeding sites for these mosquitoes and eventually people coming down with malaria. How are you trying to, you know, collaborate with the relevant agencies just so that, I mean, if we get our sanitation right, you know, and all of that, we can be able to reduce the number of those that are coming down with malaria? Is there a collaboration with other agencies to see how this really works?
No, thanks, Stan. That's a very good question. Before I come to Nigeria specifically, I'll give an example of Uganda, where the parliament has made a decision that every single ministry has to have a budget line for malaria prevention. Whether you're Ministry of Education, Gender, Infrastructure, Development, whatever, you have to have a budget line. And that is what we're saying with this new strategy as well. In Nigeria specifically, what exactly you described. You know, in some parts of the country where it's a rice growing field, we know rice has stagnant water. Stagnant water breeds mosquitoes. So is it the Ministry of Agriculture to take care of the mosquitoes, or is it the Ministry of Health? What we're saying is that we need to come around the table together, sit down, and let's start allocating who does what so that we can continue to fight malaria. So in this big push and in the conversations we've had over the last few days with Professor Pate and others, we are bringing in the other sectors as well. Today, actually, as part of our seminar, we're bringing in the World Bank, bringing in financiers to come and be part of this discussion, part of this fight. Yesterday, we had the private sector there as well. So what we are saying is that the time is now to now start thinking of malaria prevention, malaria elimination differently. It cannot be from a health perspective alone. We all need to be part of the fight.
All right, thank you. And Dr. Maxwell, technically speaking, what are the biggest bottlenecks you see in terms of malaria control?
Thank you very much. There are multiple and diverse, as you can imagine. But one of the greatest issues that is encountering us now, especially in Nigeria, is how do we achieve effective coverage because of our huge population. So if we say this intervention, we need nets, we need treatment, by the time you multiply that by what is required, it becomes huge funding. And that's one of the reasons this time we are saying we need to be more strategic with even mobilizing the resources. We have to get more resources for malaria, but we have to also get more value for the use of the resources that we currently have.
But you made reference to India earlier.
Yes.
Now, India isn't quite a rich country.
Yeah.
The population is massive.
Yeah.
We're talking some 1.3, 1.4 billion people.
Yeah.
And you said they managed to do this.
Yes.
So
I'm just getting there now. So it's not enough to mobilize the resources. It's also enough to get great value for the resources that have been mobilized. So when you don't talk only about the cash, but imagine if you have bed net, please treat that bed net as a resource. Wash it, treat it. If it's torn, please sew it. Make sure that you are able to use the net for as long as possible. But if you make sure you sell the net or you do whatever you like to the net, you are making government to look for additional resources to be able to give you the net back. And if you have the net, sleep under it. If you sleep under it, the chances that you come down with case of malaria is reduced. So you might not even need to buy ACT. So we will not need to buy ACT. If you test before you treat, a number of fever cases that people are just treating, mass treating of unconfirmed cases of malaria with ACT, it will reduce the consumption of the ACT. These are the things that places with huge population like Nigeria are deploying. But this time, what are we emphasizing? We are emphasizing to say that the malaria intervention, we now have multiple tools. And all these tools, we also need to be sensible in deploying them. We are using information to be able to look at what is the what's the best combination that will be effective most in an area. Let me give an example. In the northern part of Nigeria, the transmission of malaria is more seasonal than the southern part of Nigeria. So what we mean is that 60% of transmission in areas like Kano, like Sokoto, will happen within 4 to 6 months. When we know that that's where it's happening, let's target it and reduce that 60% of the transmission. And these are some of the things that we are deploying to make sure that we use the resources efficiently so that we can also have great impact.
All right, many
another,
thanks. Okay.
Another challenge are these emerging cases of climate change, resistance to insecticide, resistance to treatment. It's not that they are here, but sensibly, we should not wait until they're here. We shouldn't wait until we have cases of resistance before we start planning for resistance, because it will be too late. Children will be dying. So we need to put in place mechanisms to ensure that we don't put too much pressure from the molecules that we are using, that is drug, and insecticide that we are using, so that we can eliminate malaria before that resistance.
All right. Many thanks, Dr. Maxwell. You didn't add that they shouldn't use the nets for fishing, because I hear that. Anyways, you talked about testing earlier, and I'm thinking that how do you want to bring the medical personnel into all of this? Because if you don't get testing right, of course, there'll be a lot of issues and complications. And we know that as far as testing is concerned, the issues are much. Qualified personnel, the right reagents, the right knowledge and all of that to do the testing right and get the accurate result. What are you doing in that regard, just so that we do not miss it at the point of testing?
You're absolutely right. And there are many mechanisms of determining whether a patient has malaria. There's a very simple procedure. We call it rapid diagnostic test. If you can do it, you can even self-apply it. Just apply the needle, put the small blood and buffer, and then it will give you the results. So you can even read the results yourself. And we're encouraging everywhere that should be distributed and should be applied. Although what you describe is the microscopy, in which you go to an hospital where there's a microscope, there's a trained personnel that needs to read the microscope, the reagent, all the things you describe are perfectly the issue we grapple with. How do we ensure at the microscopy level that is of good quality? In addition to proper training before they are recruited, we ensure that, remember I mentioned NAFDAC, that all the reagents are of good quality. And of course, those people are actually also supervised by external superior, personnel of their profession to ensure that what they are doing is in compliance with what is expected. At the microscopy level, it's also even bigger than malaria, because you use microscope to test many things, to test for TB, to test for malaria, and to test for any other disease. So the issue of quality assurance of what comes out of our laboratories is very critical, and that is ongoing. But for malaria, we are also encouraging the use of that rapid diagnostic test, not only in public sector, also in private sector. That's another thing I would like to add when somebody asks question around Lagos. Lagos has huge private sector, and people are testing, people are treating, and that they are working that's why leadership is very important, because the Lagos state government is actually working hand in hand with the private sector to ensure that what private sector is doing and what public sector is doing is adding together for the real good of the state.
All right, Dr. Maxwell, thank you very much. Let me get back to Kalu Kago now. What would you say is missing from the way we communicate malaria issues to ordinary Nigerians?
I think I was talking with Dr. Kolawole Maxwell day before yesterday, and there's a salient point he made, which was that the greatest danger of malaria is that it's been normalized. It's an everyday part of life. So the people are desensitized to the danger, the prevalent menace malaria has in our lives. And so the main thing is to reintroduce malaria for the evil that it is, and how it has really eaten into our fabric and how it's destroying our society and, affecting our children and stuff like that. I think that's a major thing, and that is where Nollywood can come as a media to reinforce that and bring that up and say, look, this is a problem. We need to readdress it. Each family has to readdress it and say, look at the various points, because it is affecting you, especially the ones who are not, like he said, not well-to-do, who are poor. These are the responsibility, the little steps you can take to mitigate all these things. And also, like Dr. Charles said, leadership, holding the leadership more accountable. Like if it's the local community, the ballets or the chiefs of the community, and say, look, we heard the government did this or is doing this. What can you do to help us with our society? When are they coming to what do you call it? To spray our environment, fumigate, stuff like that. When are they coming? So to hold them more accountable. So that's why the importance of reintroducing malaria for the evil that it is important to every facet of society. I think that can be a great start to this.
All right, many thanks, Kalu. Mr. Ikmimoye, I'm thinking about the hinterlands. I talked about the out-of-pocket spending earlier, and if you want to look at the hinterlands, access to medical facilities is, for many, it's not available. So they have to depend on one, maybe whatever it is, whether the person is qualified or not to get their drugs and all of that. So that's like an issue. How this big push, really, if it doesn't involve making medical facilities accessible to every Nigerian, irrespective of where they live, do you see this a reality?
You're right. If Nigerians in the rural areas, in the hinterlands, in the hard-to-reach areas don't have access to good medical health care, then we're joking. But that's why we are confronting this in a new way. Now, what the civil society is doing, even currently, working with the local governments, the primary health care centers, and helping to link the primary health care society center with the leadership of the society. You see, when we're talking about health, let's look at the human angle. The healthcare worker is also a human being, a mother, a father, an uncle, just a regular person like us. And we send them to work in the rural areas, hard-to-reach areas. And those are areas that when people go ordinarily, you are thinking of security, you are thinking of comfort, but the health worker sometimes is just there alone. So one of the things that we're doing now is engaging with the traditional leadership of those societies to also say that you need to care for your health care worker so that your health care worker can care for you. For instance, this person is there serving us. She's the midwife, she's the pharmacist, because many of those PHCs are chronically understaffed. And yet doesn't have a place to stay. So sometimes they have to come, travel 2 hours to work, and then go back to wherever they stay. So supposing that the traditional community provides housing for their healthcare worker so she can stay and take care of them. So that's cooperation, collaboration between the people and the healthcare worker has to be established. And we need to understand that this is not a government thing. The government is not going to do everything. We, the people, the common people like us, we also have to get into the arena and understand that our health is personal to us. We cannot outsource our health to government. Yes, government has to give us leadership. But the thing about leadership is when there's leadership, there's got to be followership. So if the government is pushing, then we also have to pull. We have to accept and make the best use of the services. So back to the point, yes, the people in the hinterland need services, but in many of those places, the primary healthcare centers are there. The issue now is how to make them more operational, how to also ensure that the healthcare workers are able to give us the best services. The civil society is already working on that. And what we are trying to do now is to expand the coverage through our community-led monitoring and ensure that that synergy is built up.
All right, thank you very much. Okay, please do.
What
Please do.
both of them has mentioned. You know, I try to emphasize the fact that you can get to hospital or clinic and find HIV/AIDS clinic or TB clinic, but you not find malaria clinic.
Ordinary malaria, like you say.
Thank you. Ordinary malaria one. But also, it's the enormity, and we had to cover all. Remember, the target in malaria is to eliminate, it's not to control. So the appropriate intervention has to reach everyone. And what the data is showing is that if you live in Nigeria, for all the population that are living in Nigeria, 80% of the people that are dying from malaria in Nigeria, they are under 5. It means that they are unable to speak, and they are dying in thousands, you know. And so we really need to hold ourselves, Nollywood, people in the community, speak for these children, because that's why we call them vulnerable. Not that all adults don't die, but 80% of the people that die, they are under 5. And NTA staff, everybody here, we all need to speak on behalf of them. And if you now go to the way malaria intervention are being deployed, as we speak, there are some interventions that are not hospital-based. We go house to house. All those hinterland you described, we attempt to take the SPAQ for seasonal malaria chemo prevention to them. The mosquito net, we attempt to go to even where there are conflicts, where there are insecurity, in Borno, in anywhere you can imagine. We try to go. So our volunteers, our health workers, they are actually risking their lives to ensure that every person in Nigeria receives the intervention. That is why it's so important that if we go through all this to get the drugs or the interventions to you, please use them so that you can be protected. Let's imagine you have the net and you sleep under it. Half of the cases of malaria will be prevented. Let's imagine that you have the SMC drugs, and 75% to 80% of the cases will be prevented. So you will not even need to be looking for the health facility because you will be protected. And this is our aim, to be able to establish and make enough of this noise so that we can break the transmission. Once we break the transmission, our road to elimination is very near.
When you say SMC, what's that?
Seasonal malaria chemo prevention. This is the intervention we give to children between 3 to 59 months in areas where the transmission is seasonal and is high. So in the 22 states of Nigeria in the north, we do that intervention. And it's going on now.
They take it before they eventually come down with malaria?
Yes.
Okay. So it's like a vaccination?
Exactly. You can call it vaccination, but we call it chemo prevention. A drug to prevent. So a drug you take to prevent you from having. So in FCT, if they have not been to your house this time, please let us know, because we need to get to everyone's house. They have not been to my house. Okay, we need to discuss it. And if you have eligible children in your house, you must be treated. Even if you don't, they will paste something on your door or a mark to show that they've been here. They found out that you don't have a child that is under 5.
Okay, anyways.
So usually shortly before the rainy season, so that's when the mosquitoes breed
all right.
a lot.
Now you talked about children. What about the M21 vaccine that was rolled out some time ago in Kebbi and Bayelsa? What's the situation with that?
Yes. So we said multiple tools. So vaccine is inclusive. That is going on in Kebbi and Bayelsa. And what we are finding out is that, like any vaccine, it has to fit into the routine vaccination process in Nigeria. And we are learning a lot from the initial rollout. Learning a lot in the sense that we are looking at the number of months recommended by WHO for children to receive the vaccines, and finding out that some of those touch points, we call touch points, are out of sync, or when mothers come to collect vaccination. You know, it's not only malaria that they will collect. And we are looking into it, that how do we encourage them to be able to come and receive this vaccine? How do we make sure we remind them when we are going to the household for SMC, for example, in Kebbi, to be able to give them SMC. And what we are now piloting in the remaining cycle in Kebbi is that when you get to a household, you give a SMC. You also ask them, have you received your malaria vaccine? If your answer is yes or no, please go and receive. And we saw almost 10 folds of people now going to receive the malaria vaccine. So we are extremely very happy about the uptake that is going on there now.
All right. Thank you very much. Dr. Charles, I'm just wondering how critical is local production of commodities in ensuring sustainability? Yeah.
I mean, local production is very, very critical, and this current government is doing everything to ensure local production. Let me give you an example. Malaria commodities over the years, whether it's bed nets, medication, IRS, it's all come from abroad. And it's all come from outside of Africa, even to be specific. And if we're saying that 95% of the global cases is on this continent and we're not producing, then that's really an issue, a problem. So this current government, led by the Minister of Health, Professor Pate, has really made it a priority to say local production has to begin as soon as possible. So actually, that this month, or I think this month, there's actually going to be a groundbreaking for the production of nets, bed nets, so that we can start doing it. And, you know, producing it in our country is not just a matter of, you know, producing malaria commodities, but it's also about job security, creating jobs for our people. A population of Nigeria of over 200 million, and we're producing, you know, it's going to create a lot of jobs. And we don't just want to produce for Nigeria, we want to produce for West Africa and even beyond.
But are the conditions right yet?
The conditions are...
Because you talk about cost of production, you want to have power and all of those.
The conditions are getting right. I wouldn't say they're right at the moment, but I think a lot of effort is being made, including concessions, to ensure that, you know, the factories can kickstart. So I think there's a lot of conversations, a lot of discussions with the Ministry of Health, with the Presidency, with the Ministry of Health as well, to ensure that those conditions are right and we can attract, you know, the right kind of skills to ensure that we can do this.
Oh, all right, Dr. Monson.
Sorry, if I can just add to that. Just this week, there's a national dialogue on power for the health sector. Because just
power
like
for the health sector.
Health sector. So just this week. So in recognition of the issues you are talking about, it's not enough to establish a factory or to set up facilities. If they don't have power, then it's not going to be optimized. So that discussion is going on now. And another discussion that went on just last week was domestic resourcing for health, so that we do not keep depending on outsiders to fund our health care. So those discussions are going on. We are bringing our best minds. We are bringing the technical people. We are bringing the civil society, traditional leaders, religious leaders, CSOs, everybody now talking together to find the best ways to go. So,
all right. Dr. Maxwell, I'm just thinking that if we do not shatter some misconceptions about malaria, this big push may not be quite successful. Say, for example, a lot of people, like Victor said, this is not malaria. You know, it's one of the easiest things they think they can deal with. That's one. Then two, a lot of people would prefer to use leaves, barks, and all of that to treat. I mean, and I know doctors like you would, you know, disabuse Nigerians from using that. Then there's also the belief by mothers these days that every 3 months, whether your child is ill or not, just take anti-malaria.
Wow.
Right? It's ongoing. A lot of people do it. In fact, school has resumed. Some people will tell you, once your child is resuming school, take anti-malaria. Just so how can we really, deal with all of that? It's a mindset thing, because if we can change all of that, then I think we'll go some way, right?
Yeah, you're absolutely right. And I mean, that's why we need Nollywood, we need you, we need media, we need the mothers themselves. Because malaria has been with us, and it's been responsible before now for almost all the diseases. I mean, when we're training in school, they say common things occur commonly. So even before the test, just treat for malaria. But things have changed. And that's why we're encouraging even clinicians to move away from diagnosing malaria from clinical symptoms. Please always do it by parasitological. Take the blood, test whether the parasite is there. It will encourage, it will help all of us. Imagine if the parasite is there and you give the appropriate drug and the person still didn't get well. It's a very important evidence so that we can see, is it that the drug is not working? Is it that the parasite is behaving stubborn? It's so that we can
mutating.
Or we can do something. But if you don't do that, then everybody is just doing what we are doing blindly. And in this age and day that we are, we should stop doing that, because the life of our patients is very important. But it's not only when you meet somebody that has what we call uncomplicated malaria. It's even very important when it has become severe. And severe means the time that you need to actually act to prevent that person from dying is very short. You have like 24 to 48 hours. If you don't take a decision to make sure that that child is receiving appropriate medication, the child is dead. And that's standard way of why we have 80% of them being the one that are dead. So we need to combat this. It starts from even the clinicians. That's what I'm trying to say. Say the right thing to the mothers. Guide them very well. Don't rush. Don't be very clear what you... I went to one state to monitor the seasonal malaria chemo prevention, because we are testing the assumption. The assumption is every child, if you receive SMC drugs, 75 to 80% of the cases should not happen. So I went to the household to go and find out household of a child that they've brought to the clinic within that time with malaria, and it was positive. And when I got to that household, I said, "Mother, have you received drugs?" She said, "Yes." "Have you given?" She said, "Yes." Oh, that's interesting to me. So maybe the drug is not working. But when I found out, rather than for her to give 2 drugs in day 1, 1 day 2, 1 day 3, she's giving 1, 1, 1.
So the wrong footing.
Exactly. So it's not enough for you to say, "I've treated you," then go home. We need to follow up. This is the basic way.
So that means your message should go beyond just using English. You need to begin to speak the languages that the mothers understand.
Exactly. Even if you imagine if you are even meeting a mother that probably cannot speak well, or it has some challenges with speeches and so on. So you have to even put it in a diagrammatic manner that you can really show that this is how this thing goes, so that the mother can understand. And that is why the equity comes to bear. You don't only focus on all of us that are in the urban area, all of us that are literate. You actually need to start from those people. I mean, I want to give an example of Kogi State. During this area, it floods very well everywhere, but I'm just using Kogi as an example. We've planned to distribute seasonal malaria chemo prevention. We've targeted, because it has to be every 28 days, we've targeted to go to your place, and then bingo, there is flooding. So what do? Everybody, you can't access them. So we have to now be working with NIMET, the meteorological agency for Nigeria, to know rain predictions, and we can use that to plan. But in addition, if there's flooding, we need to know where they have gone, because some of the population, they have to move
to higher ground,
to another place. We need to track them to where they have gone to make sure that these children are treated.
All right. Thank you, Dr. Maxwell. Now that we are talking messaging, let me get back again to Kali Cargo. If you were to do a short film or even a campaign on malaria, for instance, what message would you like to send out first?
I think through the vehicle of the actual culture of the area. Of course, it has to be targeted, that is, specified community. We have to know which community we're talking to, what parts of the country we're talking to. The message we would send most likely would be preventive.
Yeah.
First of all, preventive. So that after that, then treatment, but preventive. Things like mosquito nets, things like sanitizing your environment, how important that is. Obviously, you have to surmount whatever taboos or cultures that may be prevalent in that area. Do research on that, and then prevention first, and then if by chance this happens, treatment and how to follow up on that treatment, like Dr. Kolawole said. We are able to have that diagrammatic way of taking drugs. Like if you're supposed to take these drugs, take it this way. Follow the prescriptions, adhere to them, because these are the consequences of not following through with it, and not just to assume that anything fever is malaria. So these are the steps you can do, and it can be done within 10 minutes. A 10-minute short film, 5-minute short film, 30 minutes, whichever the case may be. Obviously, the shorter it is, the more punchy it has to be, and most times it will have to be pictorial. It might not necessarily be much dialogue. The longer it is, then you have a story.
Attention span.
Yeah, attention. Well, a story that will guide them through. But the shorter it is, the more visual, impactful or visual it has to be.
All right.
Largely.
Kalu, you talked about the movies, and I'm thinking that what kind of movie do you want to make now that will get to the village woman and she would understand? Because, I mean, you guys are targeting Netflix, you're targeting, I mean, those are the kind of movies you're making these days. So tell me, because I want to know, how, my grandmother in the village can actually access your film and be able to understand what you're saying, because these days the content in our movies are international standard, right?
Well, I think that's a misconception, because Nollywood actually covers all facets. You have Netflix, the big streaming services. You have YouTube. You have down to the, even if we have to fall down to the ground. I mean, this is a drive. It's not. I'm not here to make money. I'm not here to say, oh, this is. We're here to combat malaria, and so to do that, we have to get down to the grassroots. If we have to do a local cinema or projection thing to, do that and go to communities and do that, we'll do that.
And probably have it in different languages, like Igbo
of course,
and all of
definitely.
that?
We'll do it in different languages and go to, the target is to go to all facets of society, and whatever means we can do that. Like I said, this is a collaboration with the government. If we're going to do that, even if we have to put up a tent or a screen in a village and do it and then project it to them in their communities, no matter how combative or whatever the case may be, we'll do it. We're not doing it for our own pockets or to, make ourselves stars. It's a campaign. It's a campaign, if that makes any sense. So that's
all right.
Can I add to that?
Please do.
I mean, what I'd like to add is, because our target has moved from control to elimination, it means it's not enough for us to focus on the behavior of individuals as it affects their protection. Yeah. It also now needs to include the behavior of individuals as it affects the entire community. Because you are not sleeping under the net to protect yourself alone, but if you hang insecticide net, and all of us are hanging insecticide treated net, it affects the transmission within that area. If you ensure that you support the mother, the child that is sick, to be able to reach the hospital on time, it makes sure that that child is treated, but the child is also cleared of parasites for the period that the child doesn't have. So the focus is now to be making us to adopt a culture. So a net use culture, for example, a testing culture, for example, so that all of us can adopt this culture so that malaria can be defeated. Thank you.
All right, thank you very much. All right, we thank you very much for staying with us. And if you've just tuned in, this is Good Morning Nigeria on the network service of the NTA. And we've been discussing the new strategies in combating malaria. Now, we have some messages in from our viewers, so we'll quickly run through them before we continue this conversation. From Jack Abba in Makudi. Many years ago, some illnesses harsher than malaria, like smallpox, were eliminated. Measles almost gone. But malaria, with several strategies, remains adamant. The question is, if mosquitoes are the real causes of malaria, why are the strategies to defeat malaria not targeted at eliminating mosquitoes, as done with tsetse flies and the likes? Okay? Interesting. And from Kasim Umar in Kanu, in mobilizing funds to tackle malaria in Nigeria, stakeholders should prioritize domestic resource mobilization, as over-reliance on development partners can be disappointing, especially considering how the United States abruptly decided to cut off aid to developing countries. And from Francis, I love your topic about malaria, and I will love you to tell me how to stop it. I guess we've been doing that all day or morning. And finally, from ACG, James Bassi, retired in Lagos. Good morning. Can we talk a little bit more on how Brazil eliminated malaria within a few months by spraying their environments, bushes, stagnant water bodies, etc., with special granules to feed mosquito larvae? The granules are formulated to burst the stomach of the larvae. That way, they don't grow to maturity. And we know that the culprit female mosquitoes don't live beyond 30 days. We need not reinvent the wheel. I urge the Honorable Minister of Health to give this solution a trial. It will work. Let's try it, Nigeria. Thank you. All right, Yenri.
All right, I'll take some of the messages I have too. This one says, good morning, I appreciate these efforts. However, I want to add that despite the threat of mosquito-induced malaria, we do not really care. Why? One, we do not respect and care for our environment, especially in the area of refuse disposal. The need to educate our children from our homes at the proper disposal of refuse so we can see it as a culture. Then lastly, give support to the society and the NGOs responsible for tackling this scourge. Arabi Kende Paul from Life Camp Abuja sends that. Another one says, good morning to you and your guests in the studio. Regarding the malaria vaccine, I don't think there's enough sensitization about it to the public. A lot of people don't know where to get it. That's Jerry Thomas from Kaduna. I think there should be reinforcement of laws that guide a cleaner environment, bringing people to book and sanction environmental offenders. What happens to Sanitation Day, which kept Nigeria super clean every Saturday per month? I really miss those days.
Last Saturday.
That's coming from Mr. B in FCT. Another one says, good morning, Nigeria. My name is Flajimi Akintude in Niger State. I love this program and you're doing this. I love the program you're doing this morning. God bless NTA. God bless Nigeria. I hope our local government people try more to distribute more mosquito nets to the people in rural areas. Unfortunately, I was in one area in Oyo State, Ogbomoso, well, it says which did not go well. I don't understand what that means. I'm sure maybe in the distribution of mosquito nets, I guess. All right, you want to respond to some of the comments that we have?
Yeah, I mean, these are interesting comments, and I thank our viewers that participated in sending them in. Let me start from the smallpox, and that's where I was trying to emphasize. Smallpox, the transmission of smallpox is different from malaria. Smallpox is a virus that is contagious and can spread by droplets, whereas malaria has two things you have to grapple with. You have the culprit itself, which is the parasite, but you have the vector. And then, of course, human beings that are the host. And this vector is a very prolific transmitter. Is very good. And this vector, all of us see mosquito, but there are different types of mosquitoes. And the one particularly that is spreading malaria is the female Anopheles, which behaves differently and lives in different environments. And the behavior is also changing. So we are trying to track this behavior, and we are also trying to track the behavior of the parasites. And what I think is critical is that we all need to then manage it a lot with evidence. I think malaria will move faster if we are all tracking it with evidence, all the things that we've discussed earlier. I also want to respond to some of the questions around, I think the last one you mentioned about
Vaccine?
about net distribution.
Yes,
and
net
vaccine.
distribution, yes.
The net distribution, we try to emphasize that the net distribution should be universal coverage. We should estimate the population in an environment, we estimate that an average of one net to an average of 2 persons.
Is it free?
We distribute it free of charge.
How are you monitoring that? Because, I mean, not every Nigerian gets it for free. You have to buy, even in health centers, sometimes.
Yes and no. I mean, let me say yes and no. Because at the time, the net is distributed average of every 3 years, which is the social life of the net. We call it social life when we expect not only because of the insecticide will have gone down, but the sleeping places, there are rats, a child has gone there and used a razor blade or whatever. So the social life of net, in which the net will still be useful, we estimate it to be 3 years. So every 3 years, you get new nets. However, every 3 years, you have new members of the community. New children are being born. New women are getting pregnant. New people are immigrating to that community. So those new populations still also need to be covered. And our expectation is that you should use what we call continuous channels to cover them. It could be at the antenatal, it could be at the EPI, it could be by the private sector, and which takes us back to the local production of malaria commodities that you mentioned. Private sector, we give specific color, specific shape, specific size of net when we give free of charge. But not all Nigerians like the color, the shape, or the size of what we distribute. Our expectation is that private sector will then reach out to Nigerians that like something different, that like nets that are made with cartoon characters, that are made with picture of Kalu, and so on and so forth, which can encourage this net culture that we talk about. We cannot expect a net factory outside of Nigeria to do that. It's only a net factory in Nigeria that knows the preferences of Nigerians and be able to respond to that. In some culture, talking about culture, some colors that we give doesn't work. It makes them feel as if they are dead people, if they are using white net or whatever. So we need to understand these are different culture and preferences and respond to them.
What about the Brazil example?
I'll respond to Brazil. So Brazil actually hasn't eliminated. They've been able to drive down the burden a lot through different methods. And some of those methods is what we also want to incorporate. You talked about larvicide, about spraying. Certainly that's what we also want to start doing here in Nigeria. We're doing it already, but how do we do it en masse so that at least we can, get to the mosquito breeding sites as soon as possible. There's also the use of AI, artificial intelligence, where in some countries they actually use drones to identify where the breeding sites and then use the drones to also spray. So those are some of the new technology, new strategies that we feel we can, bring into the conversation and into the country. The other question around domestic resource mobilization, I think is very pertinent, and a lot of our leaders are really now looking inwards to say we cannot be left dry, we cannot be left out there by one funder just pulling out funds and then we don't have enough to take care of our people. So there's a lot of effort that is being made. Yesterday we were talking almost the whole day about domestic resource mobilization. And for malaria specifically, what the country has done is that they've set up what we call the End Malaria Council, which is really private sector, public sector coming together to see how can we raise additional funding. And the chair of that End Malaria Council is actually Aliko Dangote. He was meant to be with us yesterday, but he was caught up with other matters. But these are the kind of energy, these are the kind of things we want to bring in to ensure that private sector, domestic resource mobilization, we're working together to give the additional resources that is needed to the fight against malaria.
All right. Thank you. Ayo Ekpimoye, how critical would you say the role of the civil society, which is your constituency, is in holding government accountable in terms of funding and implementation?
Okay, that is one of our most fundamental roles. Accountability, being a watchdog, being the advocate for the masses. In several areas. One, in provision of funds. Just like it's been said, we cannot continue to outsource our health to outsiders, no matter how good intention they are. They also have their own challenges. And if they now say we got to take care of ourselves, we don't blame them, because it's we who should take care of we. So ensuring that government budget for funds for malaria, we've been working on that, and we are close to it now. Just yesterday, the parliamentarians that were with us made a pledge that going forward they are going to have a budget line for malaria in the national budget, coming for the first time ever. And that's through advocacy, engagement with lawmakers who do the appropriation. Then when the funds are appropriated, they are released on time to be able to make good use of, to prevent malaria, to treat. The other thing is also deploying human resources to primary healthcare facilities. You see, even the primary healthcare facilities that we have across, we think they don't exist because many of them don't have staff. And what happens is government recruits staff, but most of the staff members stay in the state capital or local government capital. They don't go to the hinterland. So we're engaging with government that even the few staff that needs to be spread out, there has to be some level of equity. We don't keep everybody in the government. So we are doing that. And that comes with engaging with both the local government and state government. The other thing is also giving them information of what works and does not work. We know that the ability of the government staff at state levels to understand what is going on around them is severely curtailed, really. So one of the things that civil society does is we use scorecards, we have monitoring devices and systems, and report to the government. Say, this is what is happening here. For instance, you could hear a government official say, we have deployed this amount of resources to this area. We monitor and tell them, yes, it is true from your records you have, but those resources, they actually not get there, or they got there, they're being misused. Now, while I'm still on this board, let me do a small change of tack to say, we need to give some messages to our religious leaders. Now, if there were to be something or a group of people coming to kill your people, and those people will kill 20,000 children, the religious leaders will be mobilizing all-night prayer meetings, they'll be here talking, they'll be... Now, we don't have people coming to kill your children, but malaria is killing them, and you are comfortable.
Are you doing advocacy?
Yes, we are. And we are.
Because if you are reaching out, I'm sure they will welcome you.
So what we are doing now is telling religious leaders, you have to lead this fight. Your people trust your voices. Particularly, look at what we distribute nets. And like you did say, rather than sleep inside the nets, people use them for fishing. Supposing the pastor, the imam, in their sermons, keep emphasizing to the people that these nets have been distributed. Mothers ensure you sleep and your children sleep inside this net. Those become force multipliers. We multiply the efficacy of what we are doing. So the religious leaders have to come into this, really, and speak up regularly and see malaria as an enemy. We should move away from being comfortable with malaria to seeing it as it truly is.
Fantastic point. I also think that she also sensitized maybe the followers or the religious leaders, I don't know which now, such that when they have health conditions, besides just praying and fasting or going to the mountains, they should also seek medical help.
On time.
Yes, on time to deal with, some of these issues. We're about rounding up the conversation. We do not have time left. I'd like to get to Carlo now. My first question to you, I've been avoiding you. By the way, he looks very good, just like he looks in the movies that you see. So, what will be your final words, really, to Nigerians? You've talked about what malaria did to you.
Yes.
Despite your good looks, despite what you do, malaria, still dealt with you. So what's your message, really?
Well, yeah, I seem to be out there, but you also forget I'm also in the bush sometimes shooting, and that's where the mosquitoes really hit you hard and everything. So my message to Nigerians is it affects every one of us wherever you are, and the government. I'm very, very touched by, especially the passion which Dr. Kolawole. I've talked with him outside these environments. I can see the passion that they have, and Dr. Charles as well, even the minister. I was shocked at how knowledgeable and how motivated he is towards fighting this malaria. And again, let's not normalize it. Let's see it with the seriousness that it has. I call it the silent killer because it decimates our children. It affects our very lives, our livelihoods. I had to sit down at home for a while. And it affects every one of us. And let's listen to the government. And I have a lot of faith in God. And in that, I have faith in Dr. Declan Charles with his drive towards eradicating to malaria. And that is why I am personally invested in it, and Nollywood as well. So let's all join hands together, listen to us, and it's something that we're all involved in and to be to our betterment to eradicate malaria from our society.
All right, I'm sure the women heard you more than the men. We need to round off. Dr. Adekunle, like you talked about, really, I also felt the passion that which both of you spoke about all of this. How do you want to transfer this to everyone? Those people who are distributing the nets, such that they actually distribute it. Do you understand? For free, right? And not give to their friends and cronies, and they just stockpile it in their homes, and, just so that everybody who is involved in this whole thing carry the same passion and do the right thing.
Yeah, I think it all comes back to your conviction. And if you've seen children die, if you've had, encounters with malaria, which we've all had in one way or the other, I think automatically the passion should come. But as Nigerians as well, we need to change our mindset. We're not doing it for us as individuals, we're doing it for the society. And I'll just give you a brief statistic. If we're able to bring down the burden of malaria by 90% on the African continent by the year 2030, we will raise the GDP of the African continent by $127 billion US. That for me is enough motivation to say, let's do the right thing. So we need to continue to communicate, we need to continue to advocate, but more importantly, we need to see this fight as our collective fight. Everybody has a role to play, and everybody should play their role as best as possible.
All right, Dr. Maxwell, in a minute, in terms of data, how reliable is our surveillance system in being able to pull this together?
I think we are getting there because surveillance is a system, as you've said. So it includes looking at the active surveillance and then the passive surveillance and the surveillance for other diseases. But the good thing about malaria is that you can test
That's a good thing.
The good thing about malaria is that in terms of malaria control activity is that you can test the assumptions from what I've said. Some of the interventions are community-based interventions. When you do this, you should get this. If you sleep under the net, you should do this. If you take your SPAQ, you should do this. And once that starts happening, now that we're even going digitized, in the sense that we are able to get, when we get to an household, we are able to have the GPS of that house, have data for that particular child. So when we are going back next year, and so on. We know that this is the same child. So it improves the quality of our data, but it also improves the commodity safety, because you can't now play pranks. If they've received or not received, we have the data, and we are monitoring you. And we are also using AI. We want to include maps now, that in a particular setting, AI can guide us on how quickly you can cover every household. So we have an estimation of the number of households you can cover per day. And so we are in a situation where we are using technology to actually improve efficiency.
All right, many thanks. For that, we need to round up the conversation. We hope to have you, some other time, to tell us about the success stories and where we are, in dealing with all of this. Thank you so much for being our guest, Dr. Michael Adekule Charles, Rollback Malaria Chief Executive Officer. Thank you so much. It was indeed great listening to you. Dr. Kolawole Maxwell, Chair, Malaria Technical Working Group. Thank you so much, and we hope that you keep up the good work. So we can actually see results at the end of the day. Ayo Ikmemoye, Civil Society Lead, thank you. Continue to do your oversight. And, of course, the one and the only Kalu Keagu, actor. I want to say so many other things, but I don't know what my producer to to plug me. But, thank you so much. And, yes, we love your movies. We want to see more of it. More talking about malaria, of course.
Yes.
And yes, we hope that we actually eliminate malaria in Nigeria. So, that's it on the program this morning. I'm Ian Ray John. Live locked on the NTA.
And I'm Victor, so we'll see you again on Monday.